the first question actually came up from Professor Venugopal. So he was asking, Manish, what is your take on the snuff box fistula?
So the snuff box fistula works, but you will get a thrill. But what we found in our own experience was that while you get a thrill, the vein does not develop. So we
quite a bit lost Manish at this point. KP, can you come in on that?
Yeah, so we used to do it.
Did you get the answer, sir? I thought I lost Wi-Fi for some time.
Yeah, Manish, come back. Go ahead.
Manish?
KP, go ahead. I think we lost Manish.
So we used to do a lot of these before, but if we look at how all the nursing technicians or even the nurses or even as undergraduates, when we put in a cannula, you turn the patient's wrist in mid-pronation position. And the most beautiful vein which stands out there is that cephalic vein just above the radial styloid process, and you put in your cannula there. I'm sure you end up doing a fistula below that level, you're going to always hit an obstruction at that point. So a lot of times when I do the Doppler preoperatively for vascular mapping, I always end up finding a narrowing or a thrombophlebitic vein exactly at the lower wrist. So if the patient has never had a cannulation, I would still go ahead and do the fistula there. It would depend on his venous anatomy completely. So no thrombophlebitis, good open vein, stretches out nicely, then I would still consider snuff box fistula for this patient, because we're always looking at saving length of venous anatomy.
Okay, KP, continue on. There was a question from Dr. Shabnam. What is Schwartz test?
Right. You want Manish to take that? He's back online. Manish, Schwartz test?
What is Schwartz test? Either of you?
I didn't get the question, sir. I have an unstable connection.
Schwartz test?
KP, I think.
Okay.
Schwartz test. KP, you take it.
So basically what you do is you are trying to create a standing column of blood. It's something which we are used to doing when we do an evaluation of perforated incompetence, varicose veins. You're looking for a good standing column of blood. So you put in a proximal tourniquet, and then you tap on the vein which is distended, and you should be able to feel the pulsation distally as far as possible. So times are you will be able to feel this pulsation even in the upper arm, which essentially means that there is an unbroken column of blood extending from where you are creating this percussion to the point where you are able to feel this percussion in the upper arm. So essentially it means a long segment of patent vein with possibly no narrowing in between.
Yeah. Anish, there's a question from Dr. Syed Nazir. What are the important causes of early thrombosis?
Yeah. So early thrombosis, one can have actually sometimes certain factors like the atherosclerosis, or sometimes they have protein C and S deficiency, so some certain coagulation disorders. So some of these things, they need a good preoperative evaluation. But generally in a patient who doesn't give you history of a fistula which was done earlier and it blocked again, only then you will go for investigation. So the important point is, if you have one good vein and a fistula, another good vein and a radiocephalic fistula, and they are blocking, so that means there is an issue with the patient profile itself. Now, second thing is the technique. It's very important that, as I think Krishna also showed, that if you have left a bit of twist there at the end, if you have or if you have been happy getting a pulse there, don't be happy after just as soon as you release the clamp. If you don't get a good thrill, that means it's only a pulse and this is going to thrombus. So if you are very careful, technique, of course, nothing can supersede a very well done technique with all the vascular principles. So important thing is the technique, and then you see the lie, you see if there is any kind of compression, and of course a preoperative evaluation. So these are the things which one has to keep in mind for the early thrombosis.
So we can